Welcome to the Sibo Doctor Podcast with Dr Nirala Jacobi. If you're a practitioner and want to learn the basics of Sibo, head over to sibotest.com and sign up as a practitioner. This will give you access to a free 90-minute webinar on the fundamentals of Sibo treatment. If you're a patient, please know this information is not intended to diagnose or treat a medical condition. Please ask your doctor before initiating any new treatments. And now, over to Dr. Jacobi and the Sibo Doctor Podcast.
If you're like me, you're finding that treating small intestinal bacterial overgrowth can be complicated. Patients often present with a myriad of symptoms and associated conditions which require holistic thinking and a methodical approach to treatment. This podcast was born out of a desire to start a conversation with other practitioners, educators, experts, and researchers, and see if their insights can give us new treatment considerations, especially for our difficult cases. In this podcast series, our guests talk about functional gut disorders, hormonal issues, the enteric nervous system, food intolerances, the immune system, the microbiome, methylation and genomic issues, and everything else that can make a Sibo case very confusing. I believe that by understanding the often complex interconnection of Sibo with other disease manifestations, we can be more effective in our treatment approaches. I hope you find this podcast useful in your practice, and thank you for listening. Welcome back, Sibo practitioners. And with me today again is Dr. Bradley Bush. We had a fantastic interview a couple of weeks ago, and we thought we'd continue the conversation and really dive into some of the concepts he brought up last time and talk, have more case presentations around chronic Sibo cases and other inflammatory concepts. Dr. Bush received his naturopathic doctor degree from National College of Naturopathic Medicine and is currently co-owner and clinic director of Natural Medicine of Stillwater and its online practice, norvana.com. You can find that link in the podcast write-up. Dr. Bush's practice focus is fatigue, insomnia, GI disorders, mood disorders, and Lyme disease. And Dr. Bush has over 16 years of industry experience and is also owner of Natural Health Insights, providing consultant services to the natural products and laboratory testing industry. Dr. Bush speaks nationally and regularly publishes on the topics of neuroimmunology, brain-gut connections, neuroendocrinology, and Lyme disease. Dr. Bush sits on two nonprofit boards, the Naturopathic Education and Research Consortium and Compass Center for Health. He lives in Stillwater, Minnesota, with his naturopathic wife and 4 daughters. So welcome back, Dr. Bush.
Thank you, Nirala. Thank you for having me on your program.
It's been really great. I just was so thrilled to have you on again because I just think you are just such a, not radical thinker, probably you are, but it's just great way to weave concepts together. So today is a little bit of a different format where you have 3 cases that I think will demonstrate the variability of presentation as well as complexity of some Sibo cases. So how do you want to do this? Shall we start with the first case that you talked about, fibromyalgia, chronic fatigue?
Yeah, let's go there because, when there's so many people that present with extra gastrointestinal symptoms when they have Sibo, and it often the whole concept of looking for Sibo as its root cause is almost foreign to most people. You're so stuck on the gas, the bloating, the diarrhea, the constipation, that when someone presents as basically a train wreck on many different levels, many doctors will say, okay, well, maybe there's Sibo, but I'm going to be more interested in doing these other things. And I always tell patients, our clinic, my approach is in the world of sports, in the American baseball analogy, is that we play small ball. I don't try to hit a home run with every patient all the time. At the end of the day, I'm going to follow the breadcrumb of logic and laboratory testing to find a root cause behind problems, fix it, wait for the dust to settle, and then move forward. And with really complex cases, when you look and see an obvious Sibo case, it is imperative to treat that Sibo first and foremost before going anywhere else. Without that epicenter of health, the intestinal health, without that being a strong foundation, you cannot grow good health. And so, a good example here is my very first ever Sibo diagnosed patient. She is a 65-year-old female. She came to my clinic with a over 30-year diagnosis of chronic fatigue fibromyalgia. And as you know, chronic fatigue fibromyalgia is a descriptive term. I mean, yeah, it's been recognized as a quote unquote condition. That's BS. It's a way to describe someone. You don't all of a sudden get the chronic fatigue virus. You don't get you don't have a genetic disorder to all of a sudden say I have chronic fatigue. Something happens, and there's usually a domino effect. Well, here in the United States, when people have this chronic fatigue fibromyalgia diagnosis and they do nothing but suffer year in and year out, this beautiful thing called polypharmacy occurs. Because this person obviously is very deficient in many pharmaceuticals, they decide after seeing one doctor after another to try every single pharmaceutical with this person, and most of the time forget to take her off, or one doctor doesn't want to take them off of another med because another doctor prescribed it, even though they don't see that doctor, and they just stay on them. In her particular case, this woman presented on two antidepressants, an SSRI and an SNRI. She was on Ambien. She had Ativan. She was on Ritalin, and the Ritalin had just been changed over to Vyvanse, different amphetamine stimulants. And she came to see me. When she saw me, and this is one of those great moments in your career where it reminds you of some very important, just basic things, like don't judge a book by its cover. Because I swear, Nirala, she came in, she was so scattered. She kept twitching. She kept moving around. She was fidgeting. She was jerking. She couldn't finish a sentence. And along all her arms were these red spots that she was trying not to pick, but kept picking and scratching. Of course, some blood streaks here and there. And I looked at her. Her front teeth had rot on them. And she's telling me this story. She goes, about her journey and about how, she's on all these different things. She's so exhausted. She can't think. She's got brain fog, and she's in constant pain. She's always tired. And as she's talking to me, all I can think about is that she's on methamphetamines.
Yeah, that's what I was thinking. But
that's all I can think about.
But I'm horrified by all the meds that she was on. I mean that.
Oh, absolutely.
Yeah.
And I like to say that that's unusual, but yeah, that's not unusual in my practice, unfortunately. So here she is, and I'm trying to get this story. I couldn't even do a full intake because she just couldn't sit still. And then she comes back, and I finish it up, and we started doing some stuff, and I got her neurotransmitters tested, and we looked at her basic chemistries. Well, her basic chemistries came back with massive inflammation. Her C-reactive protein was like about 7.4. I mean, wicked high. Her thyroid was off, go figure. Even her serum cortisol was a very low normal. And one thing that really jumped out at me, though, was that her Milo Peroxidase enzyme was really high. And do you measure Milo Peroxidase?
No, but you mentioned it last time. I think I will start to look at that a little closer. Can you elaborate on that again for new listeners?
Yeah, so myeloperoxidase is an enzyme secreted by neutrophils. And the neutrophils are that white blood cell that loves to protect tissue borders, and of course are found patrolling around all of your epithelial layers. It was invented by the Cleveland Heart Lab for evaluating severity of advanced cardiovascular disease, where your blood vessels become damaged. But one of the main interfering factors for that cardiovascular assessment is irritable bowel. And whether it be irritable bowel disease or irritable bowel syndrome, you often get a increase in myeloperoxidase. So lo and behold, when you have neutrophils that are very active, one thing about a neutrophil is that, if a white blood cell is the nice cop on the beat, the neutrophil is like the special ops high on crack. They not saying that our special ops are. I'm just saying that these guys will go in, blow down any cell in its way, and completely neutralize and kill everything in its path because it was designed to keep us from being infected by something bad, i.e., if Ebola is in the environment, a neutrophil is going to go in and try to attack it and kill it. But unfortunately, neutrophils don't really differentiate the difference between, hey, here's a lipopolysaccharide from a bacteria, and here is Ebola. They treat it all the same. And likewise, what happens is when they're very active, they cause tissue damage. And so that is one of the reasons why there's sometimes a perpetual immune induced leaky gut or compromised intestinal barrier. And so
Can I ask a question about that? So
Sure.
when you have high myeloperoxidase, I'm just trying to clarify, it's non-specific, right? You're saying it could be just because of high LPS or lipopolysaccharide from gram-negative bacteria, as is the case with Sibo and leaky gut, or it could be chronic infection from other sources, like could be Epstein-Barr even, or it could be another sort of type of infection. Is that correct?
It could be. It's going to be an infection in a tissue, and it's going to have to be a tissue with a lot of epithelial cells.
I see. Mm-hmm. Like the gut.
When you have, like the gut, and even I had a patient who had colon cancer. She was trying to treat it naturally. She also had Sibo on top of it. Nice double whammy. And of course, you want to go back to that conversation. Was that the chicken or the egg? But when you have a colon cancer, your myeloperoxidases are about 300 times the normal level. So, and that's actually, somewhat of a good sign too, but then you could use that as a tracker to see if your treatments against the colon cancer are effective also. And that's in literature. So, it's not specific, but the way that I've looked at it, and it's been very, very helpful in this regard, is that if this person doesn't have a long-standing cardiovascular disease with some atherosclerosis, it is more than likely gut related. And when I see that high MPO, the first thing I think of is, all right, symptom-wise, what are we looking at? Is this person fit more of a Sibo dysbiosis, or is it maybe some other type of pathogen? So I kind of weigh, do I do a breath test or do we do a stool test? I'm not the biggest stool test fan, and so I usually try and rule out Sibo first because it's more common, especially with people suffering with constipation. This woman, with a 65-year-old chronic fatigue fibromyalgia woman, has had constipation for about 40 years. And so I'm like, great, we'll do the Sibo test. It comes back rocket high. I mean, she was through the roof high hydrogen. It was 129 points. Boom. Increase. So yeah, all right. Okay, I have a good idea. I know you're on all these different things. We're helping you out. We started doing some neurotransmitter balancing. Her monoamine neurotransmitters were in the toilet, which isn't surprising. Anyone with chronic inflammation we'll get a upregulation in the indolamine dioxinase enzyme, and which will downregulate and decrease synthesis of your serotonin. In time, you'll get other enzymes that get downregulated and get less catecholamines produced. And lo and behold, she had half the level of your serotonin you should. Even when she was on an SSRI, she was at half the level of norepinephrine that she should have, and she was on not only a norepinephrine reuptake inhibitor, but she was also on Vyvanse, a major amphetamine stimulant. So it's like, this is a person whose entire stores are drained, and the medications can't pull out her neurotransmitters enough to even get her normal. So with that much said, we put her on a 2-week botanical protocol initially to help clear out not only any residual yeast, which I always say that when Sibo is around, its best buddy, yeast, is right along with it, because Sibo is sort of a generator of dysfunction that yeast likes to come and party with. So we kind of clear out, start killing off some of the Sibo bugs and the yeast with using some botanicals. And then we switched over to rifaximin and for 2 weeks, and followed by rifaximin and metronidazole for 2 weeks. And she was 80% better after that second round. 80% better of her pain and her fatigue gone. And it was just like, that was you got to be kidding me. Like, really? And she kept improving after that as she maintained on the diet improvements and kept up with botanicals. We always do botanicals for 1 to 3 months after a round of antibiotics if we have to use antibiotics. And lo and behold, now she's off of most of her meds. We got her off the Vyvanse and the Wellbutrin and the SSRI and the Ativan rather quickly. And so it was quite once again, if you have massive dysfunction creating huge amounts of inflammation, once you pull that away, the body can start balancing it, and then you just have to replete what was depleted.
I have a couple questions. How come you decided to use metronidazole in conjunction with rifaximin? Why didn't you just go with rifaximin?
For 2 reasons. One, I was very afraid of C. diff with her. When you have someone who pretty much has very little life force, who's had GI issues for a very long time, I did not trust that her immune system would actually be competent enough to not get C. diff. Especially since, maybe I was a little even gun shy, just because the backstory was that she's even though I thought she was a meth user, I found out that she was actually a strong pillar in our community, whose husband was a very well-known person, and I guess she's part of many different boards and helps people out all over the place. Shame on me. Many of her kids are doctors and physicians in the area. That goes back to the don't judge that book by the cover thing. But we commonly will use metronidazole in the research. Metronidazole has been shown to be one of the better treatments for rifaximin-resistant Sibo. And in addition to, it is also the preferred treatment for C. diff. So we commonly will actually put metronidazole in the second round if we have to use rifaximin a second time. And outside of acute onset Sibo, most everyone needs at least 2 rounds of the rifaximin if we're using it.
Very interesting, because I'm always so gun shy of broad spectrum antibiotics. And listeners have heard me say this before, but And this is always a tricky call to make as a practitioner, because you have people that are so dysregulated that sometimes they do need big guns like that. But where we come from, as naturopathic doctors, we're sort of the custodians of the microbiome. That was a quote from Dr. Jason Horlak that I really took on board, because I resonate with that people's microbiome have been so dysregulated and assaulted from multiple medications that I personally have a bit of a gun-shy view of broad spectrum antimicrobials. But it sounds like that was, and this is the reason I have the show, because I'm always curious, okay, how is it working out there? What are we seeing when people are on metronidazole other antibiotics? What's the fallout from that? I mean, do you then try to rebuild? I mean, of course you do. I'm assuming you then rebuild the microbiome and work with that to bring some sort of normalcy back to this person's microbiome.
Well, of course, couple things, and I have to deal with a broad spectrum of patients also, and the biggest challenge is that you'll have a patient and they've been working for so many years trying to get themselves together, and they've maybe just come off of, and I've had a number of patients like this, they're just coming off 2 years of being on the GAPS diet. And they've gotten rid of their joint aches, they've gotten rid of most of their depression, but yet they still have all these other problems going on. And you diagnose them with Sibo, and it's like, and here's this come to reality moment. It's like, okay, you basically taught yourself to have an eating disorder, which eventually many people do when they're on these highly restricted diets for that long. I don't care who you are. I mean, I myself have created myself even eating disorder on the elemental diet, my own self. So it's like, okay, well, I mean, this is, once you're stuck in that loop, it's sometimes hard to break it. And yes, you helped yourself, but let's talk about why you helped yourself. You've been suppressing this growth that you're very hypersensitive to, and you're having not only GI symptoms from it, but extra GI symptoms. And that's preventing you from actually having a functional life. So, here's this moment. You have this opportunity. You can try botanicals and work with those, and I'm for that. It depends on how dedicated you are to that. Can you maintain what you're doing, go on the botanicals, treat yourself, and then let's retest and see where you're at? Or is your dysfunction so great that you might need an extra little boost in the right direction? Now, when it comes to using antibiotics for Sibo, a couple of things that I kind of just hold out is like, hey, if you've never had antibiotics in your life before, I'm not going to tell you to start with an antibiotic right off the bat. That's why I do that, because once again, you actually have a good gut flora. If you are another person, I mean, you spent your whole life with ear infections on multiple antibiotics, and now you have other problems. Go figure, because you had a dairy allergy or sensitivity that you never addressed. Now it's like, okay, well, how compliant are you going to be? Are you going to stay on a 1 to 3 to 6 month treatment that's going to be highly restricted to your diet and with expensive botanicals? Or am I going to put you through a 2 or 4 week protocol to get you feeling 80% better, to convince you better stay in this better quality of lifestyle, and use some of these botanicals to continue the treatment forward? Because, hey, antibiotics are good. They're not perfect. And they're not even effective for 25% of the people. And so, which I always tell the patient, at the end of the day, our standard protocol at our clinic is a combination of botanicals and antibiotics, and botanicals and diet. And from our experience so far is that 25% of the people get their butts handed to them on the botanicals. 25% of the people will get their butts handed to them on the antibiotics. 50% of the people will just do better overall. And of course, if you pull that out and look at your percentages elsewhere, it's like, hey, I already know there's a number of people that do not get therapeutic value for the botanicals, but do on the antibiotics, and vice versa. So it's not, at the end of the day, as a naturopath, my goal is treat the person to get them in the most best homeostasis environment possible to let their body continue the healing. And when it comes to gut flora, will do the protective mechanisms when they're on the antibiotics. So they always get a Saccharomyces boulardii when they're on the antibiotic. They get a probiotic at nighttime to help keep off some of the yeast and keep a little of the flora going on. And then afterwards, we do a really high potency probiotic bombardment to kind of like help in at least moving the body in the right direction. But at the end of the day, Nirala, and you probably are aware of this, you can't take enough probiotics to actually make a change in your gut flora.
No. They're just modulators. I mean, that's what I usually think about. They're metabolic and immunological modulators. They're not really there to repopulate because the diversity is far beyond just lactobacillus and bifidobacterium. We're not really there yet where we can just orally supplement somebody's complete microbiome. So exactly. I agree with that. And look, I am just always so interested what works out there, and it certainly sounds like that it was just an amazing turnaround with this patient. What are the botanicals that you frequently use?
Some of our standards is like a gel cap of oregano oil and a couple other botanicals, which is commonly used, I believe, in natural medicine and published by Dr. Seibecker and Sandberg Lewis. So that's an easy, straightforward one that we start with, along with berberines. And we used to use a highly concentrated berberine extract. And then we use neem. So I always start with that as an initial one for the most part. If I'm afraid that a regular gel capsule of essential oils is going to be too harsh for an early upper GI die-off, or if they have more irritated mucosal membranes up in the upper GI, I'll start then with a different product that's enteric-coated, that has the oregano oil, a source of berberines, and Andrographis paniculata.
Oh, good, nice. What's the name of that product? We're allowed to talk about products on our show.
Oh, okay. So yeah, that's the Medi herb gut flora complex.
Oh, okay. I use
a good Australian.
I use the Medi herb Bactocand a lot, which is a combination of essential oils, and I think they name things differently here than they do there. So I'll have to investigate what the equivalent is here. Okay. But nice, very good.
Yeah, I use Andrographis both in that particular product and even by itself for people with Milo Peroxidase being elevated, even if it's not even if you don't know if it's Sibo or not. And Andrographis itself, I had used it in an old formulation that I did for a company years ago, back before Sibo became really a big hot topic. And the Andrographis was in the GI product in a very high concentrated amount. It was amazing the immune modulating ability that it has to help in reversing a lot of even the IBD issues. And so it's a very powerful herb. I love it much.
Yeah, I mean, I sometimes use it in my formulas, but so what you're saying is that Andrographis is actually immune modulates these neutrophils to stop secreting myeloperoxidase?
Yeah, there's huge amounts of research because it's been such a common herb used in Asia for flu infections, bronchitis, asthma. And when you look at the research, it is extremely powerful downregulator of macrophages and other innate immune cells, And they've showed it could actually decrease the release of interferon gamma, tumor necrosis factor alpha and interleukin 6 by like 60 to 75%
Wow.
in these cells. And it has a strong affinity in the mucosal membrane. So it's great for not just the lungs and the sinuses, but also the intestines. So yeah, very, very, very useful herb.
Fabulous. Okay, great. Well, that was a fantastic case. Not sure if we're going to be able to cover all three, the third being Lyme, and we might actually have to do a thing on Lyme totally separately. But let's see how we go. I think the next case that you talked about was a 20-year-old with constipation, right?
Yeah, 20-year-old male. He's had constipation his entire life that he can remember. He also had acne, and of course had halitosis. And of course, right there alone, you just see Sibo walking in the door. And his story was a little unique, where he was a big sports nut and got a traumatic brain injury, a major concussion during one of his BMX bike stunts, and with that he had a lot of other issues. So he went to one of the preeminent brain injury institutions in Minneapolis that gets huge amounts of money and press, and basically their protocol, which I guess is becoming more and more standard across the states here, is they instantly put him on tricyclic antidepressants. And the tricyclic antidepressants, which can be used as a prokinetic also, but in their case, they use it because there's like a couple studies showing marginal improvement, which all I gotta say is that same amount of improvement is actually bested by fish oil, but yet they don't do that. And so he was put on a tricyclic antidepressant, and he after that he still had a lot of issues, very much always feeling spacey, very, very anxious. So he ended up trying to get off the tricyclic. Well, he ended up in the hospital twice trying to commit suicide after discontinuing his tricyclic antidepressants. So here's a 20-year-old kid, never had any emotional problems before, ended up in the hospital twice trying to commit suicide, and he's a complete nervous wreck. It's just like you can just see him vibrating. So he comes in the office, and it was one of those things where, you're a little gun shy and scared, because they're like, hey, I want to, I want help getting off this, and oh yeah, I just got out of the hospital last week, trying to kill myself. And you're like, oh great, yeah. Favorite patient of the day. All right. So we did a couple things. We did a neurotransmitter test to see what the tricyclic was actually doing to him, how much of the monoamine neurotransmitters were being mobilized and to what degree. And lo and behold, they were actually very low. So he had, once again, here's a person where at 20 years old, major athlete in his own right, and on a tricyclic, you'd expect to have healthy neurotransmitter levels, and really they were about 60 to 65% lower than across the board. So the guy was just tuned down and just not humming along, but just puttering along. So I did what you're taught never to do, and I gave some basic precursor amino acids, 5-HTP, L-DOPA, tyrosine, to him while he was on a tricyclic antidepressant.
Well, that was actually a question of mine, like it makes sense that if you cannot produce these neurotransmitters, that's why the antidepressant is not working, because you can't really have something stick around in the synapse that's not there to begin with. And so it always puzzled me, like if those levels are low. I mean, I understand overdosing somebody on precursors and going into serotonin syndrome or whatever, but it's quite rare, and especially in those that have very low monoamine neurotransmitters. I mean, why are we so hesitant to support in small amounts?
Well, in most cases, like with SSRIs, NRIs, or SNRIs, I have no problem doing that because they're really, you're not going to cause a serotonin syndrome. At least it's very, very hard to. And now tricyclics, different story. They can definitely get carried away pretty fast. So we just started really low, and just kind of gave some basic support. And of course, he felt better right away to some degree. Then we did a Sibo test, and he was rocket high, both hydrogen and methane. He was under a timetable. He needed to get better really quickly because he wanted to go to college, to university. And his parents basically said, you're not going to go to university if you are stuck on this tricyclic antidepressant and you're still a basket case. All right, well, all right, so we have 4 months to work with him. What do you do? So we, with the Sibo test, he went through about 3 weeks of of herbal antibiotics, so the botanicals, and he had some really good die-off with that. His constipation went to diarrhea, which we always love that. Thumbs up, awesome. And so then after that, he was really eager to switch over to antibiotics. So we did antibiotics. He did the rifaximin along with neomycin. He did really well on those therapies. His bowels normalized. His acne all went away. And of course, hey, if you can poop and your skin looks good and you're 20 years old, you're like totally you're like, king of the world. So he was very excited about that. He got so excited and started feeling so good, he stopped taking his amino acid supplements, which then he got worse after that. And then his parents found out, which then they said, okay, great. Now it's up to you. You pay for all the visits and the supplements, and you will get this done now in 2 months, or otherwise you're not going to school. Poor guy. But he cowboyed up. He actually came. He counted his money. He came in. He paid for everything. And eventually we lowered his tricyclic as much as we possibly could with a standard dose. And then we switched over and had the local compounding pharmacy compound it into a liquid form to allow us to titrate it further, because we tried to keep going with just a standard breaking up the tablet that he had. But what I figured out was that he was the dose would be too variable from one dose to another, and that really affected our ability to titrate properly. So we just switched to a liquid. It was a little troublesome. The compounding pharmacies don't do that very often with a tricyclic, and they have to use a larger quantity than they're used to for the proper titration. But hey, guess what? He kept doing it. He didn't get off the tricyclic in time to start the school, but because he was completely stable and he was on these microscopic little doses, parents let him go on, and he's been staying on his general support. A little, he does like that gut flora complex as the if I eat something that I'm not supposed to, I can still take the gut flora complex to knock down a little bit of the growth, so it doesn't hurt me too much, as a little management tool until he's out of school for the summer, and then do a little bit more of a real treatment. So that was a really great success story. It was very tough initially. We had some failures, when it comes to dropping the tricyclic down too fast. He didn't stick with basic amino acid support. But when it came to the Sibo, he responded extremely well to the standard methane protocol that a lot of our Sibo colleagues kind of follow. And
you mean rifaximin and neomycin?
That's correct.
Mm-hmm. Yeah, that works really well in many people. But
yeah,
my question was also about that. I mean, it sounds like another really amazing case. But one question I had about just, one of the big sort of systemic or gut-brain connection with SIBO symptoms that we see is anxiety that's purely caused by SIBO, right? So, and Dr. Seebecker has talked about this many times, and I also see that. So as soon as bacterial count goes down, people's anxiety virtually disappear. And not always, but very often, that it's actually not a what's your explanation of that? Are we back to glutamate, or what's going on there? Inflammation, neuroinflammation, and how often do you see that?
Oh, I see that quite a bit. Anxiety it's amazing, because I know there was one study, which I'm sure was poorly done, that basically said, hey, we took all these people with anxiety and we tested them for SIBO, and it wasn't very statistical there, so therefore SIBO doesn't cause anxiety. It's like, no, you don't do that. I mean, really? I mean,
yeah.
I mean, if you took all the people with constipation and diarrhea and with gas and bloating, and then you looked at how many of them had anxiety, I think that'd be impressive. But one of the keys that you see with SIBO patients, it's treatment resistant anxiety and treatment resistant insomnia. And those are the ones that are big keys, because it comes on, and in younger kids, it comes on either gradually over like a 6-month time period, or it just pops and just happens, one of the two. And they can take different sleep meds that only work for a week, and then they no longer help. Or they take the sleep meds and they still get terrible sleep, but then they're non-functional the next day. Likewise, with the anxiety, usually only really high doses of a benzo helps out, but then they're not even functional. And of course, then you risk the benzo addiction. So why does it happen? I keep wondering myself. I because it turns off so fast when you do treat it, and it does. It literally can turn off, not like a light switch, but almost like one. That I keep going back to the idea that the bacteria, I mean, they're producing this hydrogen and methane. They're producing ammonia in huge quantities and other metabolites. I think that it's actually a chemical they're producing that is hitting the neurotransmitters, affecting their signaling. I don't believe it's glutamate personally, because you don't see other glutamate antagonists, things like L-theanine being very effective.
That's true.
And it just turns off. And if it was glutamate hangs around for a while. It just can't turn off. It gets recycled and repackaged and reused quite a bit. So, but it's amazing. It's truly directly proportional to the bacterial activity. So the good news is that whatever it isn't stored, and it's not destroying the blood-brain barrier to make it quote-unquote leaky, because that would take weeks to repair, if not longer. So like I said, the good news is that I think it's very transient, and once it's gone, boom, it's gone. And of course, it's a good indicator, because once again, if it starts creeping back, they know. And so it's a good indicator of what foods to avoid, and how to keep their lifestyle more moderate.
Very good point. Well, absolutely fascinating. I think that we've touched on a lot of different topics. Do you want to dive into the Lyme case? Do you feel up for it?
Sure.
Okay, let's do it. Let's go for it.
Let's go for the Lyme thing. And if you decide you wanted to talk a little bit more about it, because I think it's such a critical part of Lyme disease that is not being taken seriously by a lot of the main Lyme prescribing docs, that once they incorporate more of a SIBO mindset with a lot of these patients, it will really help in the misdiagnosis and the overprescribing of not just botanicals, but also the antibiotics, and save a lot of people money, time, and quality of life. So I think it's huge.
Can't wait to hear your input in that, because you've alluded to it in the last session, and I'm really curious because I do see that a lot. I see a lot of people that have been years on antibiotics, doxycycline, and just not getting any better at all. And not to say that there are people out there that aren't getting better with that treatment, but I guess I see the people that don't improve with that and do have underlying SIBO. So let's go into your case.
Sure. Well, this is a nice easy case to just highlight how simple it could be, although it rarely is ever this simple. But this is a 25-year-old female who presents to the clinic. She heard a lecture of mine somewhere and thought, hey, all my friends and my family keep saying I have Lyme disease. She's been to some people that do applied kinesiology muscle testing who told her that she had Lyme disease. And so she's like, all right, well, I'm 25. I have chronic fatigue. I can barely even wake up and function all day long. She's had chronic constipation for about 15 years, ever since she was about 10. She's like, she shows her belly. She goes, I always feel like I'm pregnant. I'm so bloated. Of course, that's when you're like, oh, really? Really? Huh? Wow. Wonder what could that be? Then, but she's like, not only do I have this horrible chronic debilitating fatigue, but I have electrical impulses. Like I have these, what feels like electrical shocks shooting down my legs. And it just causes incredible pain. On a pain scale, she's like, it's a 9. And they shoot down probably, every couple minutes. And then she's like, but and I've been living like this for the last few years. I'm like, oh, really? And lo and behold, in my primary care, they ran a standard Western blot test and said, no, it's not. No history of a tick bite or anything like that. But yet, she's seen all these other people that kept telling her, it's Lyme disease, it's Lyme disease. And then we ran a alternative Lyme test, an IGeneX Western blot test, just to rule it out. In addition to that, I'm sorry, her other presenting symptom, what really drove her to come see me right away, was the fact that over the last few weeks, she started developing a catatonic stare. So she would freeze, like she wouldn't be able to move, but yet she'd regain consciousness. And she'd hear everybody and see everybody, but she couldn't move a single muscle. She couldn't move her mouth. She couldn't even blink. And she'd just be stuck. And the longest episode of that was 9 minutes.
Oh my God.
Which totally freaked out everyone that she knows. And she'd seen a neurologist that basically said they didn't find anything. And it gave her an antidepressant.
Well, it's tragic.
Yeah, it is. And then her test came back, and she was also world record incredible high methane. She had a methane. I shouldn't say world record. I'm sure you've seen some pretty high methanes. But she had a methane of 79.
I've seen much higher than that.
Oh yeah, I've seen like the hundreds.
Yeah.
But but the combined score was really impressive. 158 combined score. So it was she was rocking with the SIBO. Her IGeneX lab test came back, New York State CDC negative, and indeterminate with IGeneX criteria. And it's like, so I let her know. I'm like, well, if you were being seen by a Lyme literate medical doctor or Lyme or an ILADS trained naturopath or someone, I would tell you you'd probably be advised that you have Lyme disease and that you'd be recommended a different course of antibiotics. And I'm like, but I'm not really sure about this. Indeterminates to me on an IGeneX test are negatives. I don't interpret them as positives. And I'm not too keen, if there's a lot of chronic inflammation, to consider any type of weak positive on IGeneX as a positive. It's in my back of my head. There's a lot of false positives on when the more bands you test, the more possibility of a false positive. So I just keep that in the back of my head. So I said, let's try this. Let me have you go on a paleo diet, and then start some botanicals for the Sibo. And in all reality, I'm sorry. In this case, we got the IGeneX test back first before we got the Sibo test back, because she was late. She was late in doing the test, so I had her start on the paleo diet first. Waited for the test to come back, and then gave her the Sibo results. Well, when she went on the paleo diet, her gas and bloating went away. Go figure. And she was still constipated, but she hadn't had a catatonic stare episode, and she had no more electrical pain down her legs. And I'm like, well, good news, bad news. The good news was that your threshold for your symptoms is it so that you drop that population level by just not fertilizing it, and a lot of your symptoms went away. Hey, great news. Bad news, you still got the problem, and it's pretty bad. So we're going to treat it, and you're going to get a lot worse before you get better. So that's what we did. She started off with the botanicals first, instantly broke the constipation, went right into some raging good diarrhea. Diarrhea was really bad for a couple weeks, so we had to stop for a couple days to kind of resettle her. She begged to stop the botanicals because they were killing her, and try the antibiotics. So we went to the antibiotics, and her diarrhea came back, but not as bad. And I said, and she didn't have too many herxine from it. And I said, well, you know what? Good news, bad news. All right, your Sibo is definitely much more been depleted, been decreased by a lot. But I bet that you're definitely more susceptible to killing the Sibo with botanicals, not the antibiotics. So you're going to go back on the antibiotics. I'm sorry, you're going to go back on the botanicals, and we're going to probably experience more diarrhea. So she did. The diarrhea wasn't too bad. It was about 3 days only the second time around, and then started normalizing. Still a little bit looser stools, not perfect, but I told her that's fine. You're going to be killing things off for a while. And so she did 3 months of the botanicals afterwards, and lo and behold, no chronic fatigue, no neuralgias, no catatonic stares, no constipation, and not a single Lyme treatment in that case. Now, I say that because at the end of the day, I'm here in Minnesota, and there is a boatload of Lyme disease. Okay, we see acute Lyme disease, we see chronic Lyme disease, and I'll tell patients right off the bat, I'm not going to be the one that says you don't have chronic Lyme disease, but I'm going to be the one that says, well, what else do you have first before I go to the chronic Lyme? And as long as it's not a progressively worsening chronic Lyme. I mean, we get those too, and we have to do quick interventions. But most of the people have been treated with antibiotics for Lyme disease. Most of the time, they've been treated for multiple rounds, even years and years. And I'll tell them, at the end of the day, 33% of the patients that I see who come in saying they have chronic Lyme only have Sibo as their number one problem. That's it.
That's amazing.
Another 33% of them will have Sibo and something else wrong, but not an infection. And then another 1/3 have either chronic Lyme or an autoimmune problem. And I'll tell them, when it comes to this with Sibo, it's really a chicken or egg. You may have had Sibo before you had Lyme, gotten Lyme, got treated for Lyme, but then your Sibo ran amok. That's one possibility. You could have also just had Lyme, gotten treated by it, had to do extended treatments because you had a nasty case of Lyme or a co-infection, and then you got Sibo, And lo and behold, when you have SIBO, the extra gastrointestinal side effects it could create can mimic Lyme disease to a T. You could have the migraine joint pain, you could have the muscle pains, the fibromyalgia, the chronic fatigue, the migraines, the headaches, the pains in the neck, the shooting electrical neuropathies, the numbness. We've seen it all. You get the big spots. You get the Morgellons patients where they have the big splotches all over their body, and it's like, well, yeah, you can still get big, huge splotches with SIBO too. It just goes on and on and on. Now, I mean, I once again don't believe that SIBO is everything, but in these cases, it very well could be the most important thing. And even if they do have an infection, and I tell them, if we treat this, we're gonna clear the dust. We're gonna kick the dust up and treat it. You're gonna get lots of side effects from that, and then when it settles, we'll see what symptoms you have. And then if those look like a co-infection or Lyme, we'll do some testing to see if we can confirm that, or we can go and do some other treatments. Very, very important, because once again, in chronic Lyme, it is very much the fashion to treat on symptoms. And if you're treating on symptoms alone, symptoms lie. Just because you have a symptom doesn't equate that to what you think is causing it. And just like, when we treat someone, we think that we're treating one thing, but it might be something else. And when you look at the rotating antibiotics used for Lyme disease, many of them have poor efficacy, but still some efficacy in killing SIBO. So you get your broad spectrum antibiotics, your metronidazole, your diflucan that they pulse in and out, and you're able to knock out SIBO in a big part of the gut. At the same token, it often doesn't get 18 to 22 feet down because they're still well absorbed. And so you keep a reservoir. So what happens? Oh, look, my Lyme symptoms are so much better on antibiotics. I go off of them, and then another month or 2 or 3 months later, they all come back.
Really good point.
And you're like, yeah, what have you been eating?
Yeah, I think that's a really good point. And did you listen to Dr. Rabar's presentation at the last SIBO symposium? He did a case presentation. Actually, it was a Lyme presentation, and he's a gastroenterologist in LA, and he specializes in Lyme as well. And he had some really interesting things to say, and I plan to have him on the program as well, so I get to get his take on that. But one of his points that he talked about was, in his experience and people that he was seeing, there is a huge overlap. Something like 63% of the people that he diagnosed with Lyme disease also had SIBO. So he very much echoes what you've been saying. But one of the things that he said is, in his experience, is that people that have very high methane, it seems to be also an opportunistic infection. I'll have to confirm that with him and kind of get more sort of fleshed out on that. But I haven't really seen that, so I just wondered if you can either confirm or deny that. And in those cases that have more Lyme-like potential symptoms that mimic Lyme symptoms, do you see particularly high levels of methane in these people?
Well, the people with really high methane, you tend to see, like, if you took all the SIBO people that present with like neuralgias, though in that group, you're going to have a much higher percentage of methane producers than just hydrogen producers. So I would say, and of course, when you think of Lyme disease symptoms, the ones that really jolt at people are the electrical signals, the numbness, the tingling, the burning feet, things on that order. And so yes, I do see more methane producing versions, although it's not exclusive to it. And so it's one of those things where it's like, okay, it's a nice to know. At the same token, you can't just assume one way or the other.
Like it just makes me think sort of what's going on there. Why is methane implicated? Maybe it's related to the, I'm thinking just outside the box in terms of because of constipation, you have more endotoxemia potentially, you have more reabsorption of stuff. So one thing about methane is it's a self-perpetuating situation with constipation. So people that have high methane tend to have more methane because they're constipated. So even if you just gave something like cascara, it would reduce their methane levels because of getting their bowels moving reduces methane levels as well. So, I'm just wondering why do you think methane is more implicated in some of these neuropathies and neuralgias?
I'll kind of go with you in the same thought that you have. At the same token, I just think it goes back to the bad things that bugs produce on a regular basis. And when you talk about, populations of bacteria, I mean, Sibo is like over 400 different species of bacteria. And we just, for our own simplicity's sake, clump them together as hydrogen sulfide or hydrogen or methane producers. And of course, you could have lots of gastritis and other dysbiosis that's totally not SIBO, but something else that's just as bad. And they produce crap. They eat, they poop, and they metabolize, and they create neurotransmitters and other things. And for some reason, the methane, if I can quote someone who's in the news a lot, are real bad hombres.
Let's not quote him. He's not allowed to be quoted on my show.
Yeah, he who must not be named. So they're producing something that is going on. I don't think it's, like I said, I don't think it's a secondary. I don't think it's due to the leaky gut and then toxins being. I think it's toxins, but it's whatever they're metabolizing out. That's the issue. So. And of course, you reduce methane load and people always feel better. I mean, let's get realistic. If you're highly constipated, you become toxic. So, I always tell the patient at the end of the day, if you were a squirrel in the forest and you couldn't poop, you wouldn't be passing your genes on to the next squirrel generation. But for some reason, humans can do that.
For a very, very long time, as we know. I just wanted to clarify one thing for the listeners, because this has come up a couple times in your cases where you gave an antimethanogen, and instead of constipation, the patient developed diarrhea. And so what I make of that, because I don't see that heck of a lot. I see that a little bit, but it's not the norm that people just go from constipation to diarrhea. But so just for those listeners who are not familiar with this concept, that methanogens actually use the hydrogen from hydrogen producers to make methane, which is constipating. So when you kill off methanogens, they're unable to use the hydrogen and potentially cause a bit more diarrhea due to that. Would you agree with that?
Oh, absolutely. That could be. That's definitely one of them. In addition to the fact that when you start whacking away and killing and mowing down the bacteria, you're changing that balance. You may start reducing the methane producers before the hydrogen producers, and vice versa. So usually, once again, the sicker they are, I usually see we turn constipation into diarrhea on a regular basis.
It's interesting. I just don't see that so much, and I guess it's also because I don't use antibiotics because I can't prescribe them, and I probably, I definitely would use neomycin and rifaximin if I could prescribe them here in Australia. I regularly refer to practitioners who can. So maybe that's the difference, is that I don't see this incredible mowing down as quickly as you do.
Well, we see that with botanicals too. So now it may be the fact that I'm dealing with Americans with standard American diets.
Well, we have the standard Australian diet, so that's also sad. But
but
I think it's a different
Foster's Lager.
Oh my God! You know what? Shrimp. No one drinks Foster's here. Let me assure you. Just like nobody goes to the Outback Steakhouse. Just nobody does. Well, Well, listen, Bradley, this has been so great once again, and I hope you don't mind if we call upon your expertise again in the future. I'm sure you can help us out with difficult cases again. I like this format where we actually discuss some cases, so I might ask that for future speakers to potentially include a case, because I think it's really educational to see how other people also manage chronic cases. So I think that's really helpful.
And Nirala, thank you so much for doing this podcast and getting all these different experts together. I look forward to hearing all the other people coming on board, because listening to people in the trenches doing it is what makes the difference between being a good doctor and a better doctor. So I greatly appreciate you doing this. So thank you very much for inviting me to help share what I'm doing, and more so allowing me to learn from all these other awesome people you're going to have on the show.
That's so great. And so now how can people find you? Just I know we'll have all your contact details and all that on the podcast website, thesibodoctor.com. But just tell us briefly how people can find you.
Sure. If you have ruby slippers, you could click them a couple of times, or you can go to our clinic website and contact me through my clinic website at www.stillwaternatural.com. Our direct consumer website that will be offering also doctors to order Sibo testing or lactulose breath tests and glucose breath tests through is www.neurovana, that's neuro, Neuro, Vana, VANNA.com. And we also offer neurotransmitter testing on that also to kind of to help in connecting brain gut stuff.
That's awesome.
So otherwise, feel free. People can check out our Facebook page, Stillwater Natural Facebook page. So just do a natural medicine of Stillwater search for that. And we do kind of fun things on there. I just did a series of FaceTime live broadcasts, and we do a Whole30-Sibo class, and we just had it for free and let people join it, and we give them regular emails to keep encouraging them along. And it's one of those things where many people who in the general public might not know they have Sibo. They do all these kind of fun diets, whether it be a whole of paleo or Whole30, and they get all these great benefits, but of course those benefits don't stick because they don't connect the dots. So we try to help people out by saying, hey, if you're one of those people that lost a bunch of weight and lowered their cholesterol on the Atkins diet, maybe it wasn't the fact that you were cured by bacon. Maybe it was because you starved your gut bugs. And so
bacon and whipped cream.
Yeah, exactly. So Nirala, thank you again very much for having me on.
All right. Thanks a lot, Bradley. Until next time.
Thank you for listening to the Sibo Doctor podcast. We hope you found the information in this episode useful in the treatment of your Sibo patients. Head over to our sponsor, SiboTest.com, an online testing service for your patients and home of the Practitioner Education Portal. Tune in again for another episode of the Sibo Doctor podcast. Thanks again for listening.